Hello, my name is Emily Ramos. I'm a third-year medical student at the University of Miami. I'm here with my colleagues Kathleen Kelly and Dr. Andrew Shapiro. Our poster is called Is It More Than a Bruise? A Case Report of Dermatofibrosarcoma Protuberans in a Pediatric Patient. So as an introduction, dermatofibrosarcoma protuberans, also called DFSP, is a fibrohistiocytic tumor that makes up almost 1/5 of all cutaneous soft tissue sarcomas. The lesions are most commonly seen in adults and occur in less than 10% of the time in children and adolescents. If detected in children, it is often confused with a vascular birthmark or another common differential diagnosis. The tumor invades locally deep into the subcutaneous dermis and may require extensive wide resection that can be disfiguring. The initial presentation. We saw a previously healthy 15-year-old male who initially presented to his pediatrician for evaluation of a blue spot on the right lower back, appearing like a bruise. He denied recent trauma, fever, or pain in the area. His mother described the lesion as flat with an underlying nodule. The patient does not have a significant past medical history and no history of skin lesions. The family history is significant for a cutaneous T-cell lymphoma in his father. His pediatrician believed that the lesion was a bruise from leaning against a chair at school, and when the lesion did not resolve after 3 months, he presented to dermatology for a biopsy. An excisional biopsy revealed DFSP, an infiltration of the tumor into the subcutis, and the patient was then referred to surgery for removal. So his surgical course. A wide local excision was performed to ensure clear margins because of the irregular tentacle-like growth of DFSP. The lesion was resected in the OR with 3 centimeter margins, resulting in a specimen measuring 7 by 7 centimeters. Then pathology revealed a 1.7 centimeter DFSP specimen with widely negative margins. The lesion was identified to be final stage 1, T1A. A complex closure was performed, a drain was placed to be removed at 1 week follow-up. And although the tumor is a low-grade malignancy, the patient will continue to be monitored for recurrence and additional skin malignancy development. So to review the pathology, this first figure is a low-power view demonstrating the tumor's relationship with the epidermis. So the tumor is the bottom sort of purplish layer, and it's very close to the epidermis, which is on top. The second figure shows an intermediate magnification of the tumor infiltration into the subcutis. This last image is a high-power magnification of the tumor, and the black arrow points to an area of high mitotic activity. So in discussion, due to its rarity in children, DFSP is often a delayed diagnosis, leading to large tumors that can make excision more complicated. Recent reviews of pediatric patients demonstrated that optimal treatment of DFSP is resection with negative margins. Both wide local excision with 2 to 4 centimeter margins and Mohs surgery have been successfully used for complete resection of DFSP. For patients with positive or close margins, post-surgical radiation was used. Imatinib has been extensively used in adult patients but has not been well studied in pediatric populations, so therefore it is not often used. Wide local excision of the lesion was utilized instead of Mohs in this case because of concerns regarding tentacle-like processes and relative ease of the operative area. And as reviewed, histopathologic analysis identified tumor infiltration into the subcutis and high levels of mitosis. So in conclusion, given the potential for significant tumor burden or large surgical resection if left untreated, pediatricians should be aware of DFSP. Although an exceedingly rare diagnosis in children, DFSP should be considered in the differential of similar appearing lesions, and there should be a very low threshold to biopsy atypical appearing lesions, subcutaneous nodules, or masses. Thank you.